Welcome back to another topic of toxicology. Today I'm talking about cyanide poisoning. This is a picture of an ancient market in our country set to fire a couple of years ago. It is just to remind you that cyanide poisoning might associate carbon monoxide poisoning, as the source is more or less the same fire. Introduction. Cyanide is a mitochondrial toxin. It means that the whole process would go on the mitochondria, and it's the most lethal toxin known to human ever. Might cause death within minutes and even up to hours. Epidemiology. The most common cause of cyanide poisoning is domestic fires. Cyanide is liberated from the combustion of compounds containing carbon and nitrogen. Unfortunately, these compounds are very popular in our life and they are available in almost every place. These include wool, silk, plastic, synthetic rubber, and melamine. In industry, we might expect cyanide poisoning in those who work in mining or those who work in electroplating of jewelries, in photography, plastic, and rubber manufacturing. Medically, we might face cyanide poisoning in patients who were under infusion of nitroprusside, which is usually used in hypertensive emergencies. Now, sodium nitroprusside upon exposure to light might change into some cyanide related compounds, and patients might be uh, suffering from cyanide poisoning once they had prolonged, not everyone, but in fact those who are under prolonged nitroprusside infusion, or those who have chronic renal failure, or those who have, pediatric patients with small body weight. In the past, we've been wrapping the tubing and the pint of sodium nitroprusside with aluminum foils to prevent photodegradation of nitroprusside into cyanide related compounds. Some other miscellaneous exposures to cyanide might occur during terrorist attacks, as this mentioned in the history. In mid 90s of last century, there was some terrorist attack in Japan's subway using some cyanide related gas. Also in acetonitrile, the liquid that girls used to remove the polish from their nails, and of course from cigarette smoking. Pathophysiology. As I mentioned, it's a mitochondrial toxin. So, to remind you just that in cellular metabolism, the ATP is generated from oxidative phosphorylation, basically from the mitochondria. And the important process in the mitochondria, if you remember, oxygen transfer chain or the transport chain, is going through multiple steps, and these steps in the end they just transfer electrons through the cycles of the oxidative phosphorylation. Cyanide combines to one of those enzymes which is known as cytochrome oxidase A3. Now, importantly, it combines to ferric compound, F3, compound of that enzyme. And this enzyme, unfortunately, it is the last step in the mitochondrial uh, cytochrome complex. Once this enzyme's activity is blocked, there would be no oxidative phosphorylation. But the body needs ATP, and the ATP in this way would be not available through the aerobic metabolism, but in fact the cell is going to shift its metabolism to the anaerobic one and uses glucose to generate ATP, but in the anaerobic mechanism, and these mechanisms unluckily are liberating huge amount of lactic acid, and as you know, lactic acid is an acid and makes what? Makes acidosis. And through this mechanism of acidosis, bicarbonate would be used up, and this would end up with a wide anion gap. Similarly, we say that in these situations, the oxygen is available and available in the cell, but the cell cannot use it. This process of histotoxic hypoxia is profoundly deleterious in certain organs like the cardiovascular and the nervous system, especially the basal ganglia, the spot where the function of Parkinson's disease is evident. Cyanide is rapidly absorbed through the respiratory tract, through any mucous membrane like those of gastrointestinal tract and the skin. Once absorbed, it's quickly circulated in the body. Cyanide metabolism and neutralization involves number of mechanisms. The important one is the detoxification of cyanide via rhodanase, and this enzyme is found abundantly in many tissues including liver and muscle. Thiosulfate, which is an antidote, is a sulfur donor in the reaction catalyzed by rhodanase. This one would convert cyanide to thiocyanate, and thiocyanate conversely is a water-soluble compound that's excreted in urine easily. Another minor pathway of cyanide detoxification involves hydroxycobalamin, vitamin B12, the one that's well known to you. Circulating hydroxycobalamin combines with cyanide to change into cyanocobalamin instead of hydroxycobalamin. Cyanocobalamin is safely excreted in urine again, just like thiocyanate. Clinical presentation. Clinical features of cyanide poisoning are dependent upon the route of exposure, the duration of exposure, and how much, the amount of exposure. Signs and symptoms might include the following: headache, anxiety, confusion, vertigo, coma and seizure, and the nervous system manifestations. There might be initial tachycardia and hypertension, then bradycardia and hypotension, and sometimes there might be AV block, or the contrary, ventricular dysrhythmias, these and the cardiovascular manifestations. Respiratory manifestations: initial tachypnea and bradypnea and pulmonary edema might be expected. Gastrointestinal one, like vomiting and abdominal pain. Skin is showing up like cherry red appearance of the skin and the lips, and this is basically because there is high oxygen content of the venous side of the blood, because the oxygen is not going to be used up in the tissues and just simply traverses the tissue without being offloaded. So the venous blood contains abundant amount of oxygen and shows up as cherry red color in the skin. Cyanosis is a late finding in cyanide poisoning. We might expect renal failure and hepatic necrosis. Because of decreased utilization of oxygen, as I mentioned, in the venous blood, oxyhemoglobin concentration would be very high, and that's the reason of the bright red color of the venous side. So patients with hypotension might have apnea, might have a lot of deterioration of the clinical features, but still they doesn't show up with cyanosis. Delayed sequelae of cyanide poisoning: there might be some development of Parkinson's disease because basically the basal ganglia is affected. As I mentioned, it's a very sensitive part of the body to cyanide toxicity. CT scan or MRI might document these radiological changes. Resolution of symptoms of Parkinsonism is variable and treatment is only supportive. Chronic cyanide exposure might cause some symptoms like headache, abnormal taste, vomiting, chest pain, abdominal pain, and anxiety, but these are rather vague. It's very hard to be expected or discovered in clinical history. There are three distinct insidious syndromes with chronic low-level cyanide exposure. These namely include tobacco amblyopia, tropical ataxic neuropathy, and Leber hereditary dystrophy neuropathy. I'm not going to detail of these toxidromes because they are out of the spectrum of these lectures. Laboratory evaluations. General testing. Glucose concentration is mandatory in any patient with coma because hypoglycemia is a very good one to revert or correctable one once you give an infusion of hypertonic saline. So in every comatose patient, glucose concentration is mandatory and glucose infusion should be ready to rescue the patient. ECG is needed to rule out any sort of alternative diagnosis or reasons behind conduction defects like those caused by medications. Pregnancy test is mandatory for any woman with childbearing age. because it changes the treatment modality and the outcome. Specific testing, this includes chemistries like electrolytes and blood gas analysis. Serum lactate is mandatory because it confirms the diagnosis, in fact, and it's readily available. Normal levels of serum lactate might give a clue to the clinician to think about alternative diagnoses. Central vein gas is mandatory and it's helpful as it's showing a high concentration in the venous blood. Carboxyhemoglobin is measured by carboxyoximetry, as I mentioned in lectures of carbon monoxide poisoning. It's done especially when you suspect concomitant carbon monoxide exposure. And as we said, this is not uncommon in cyanide poisoning. Anion gap. In this situation, you might find a wide or increased anion gap because basically, as I mentioned, lactic acid is produced there and there would be consumption of bicarbonate, and this would end in wide anion gap. And I hope that you can go back to biochemistry and discover further details of this. I'm not going to embark into, in fact. Cyanide concentration or level is good and helpful in the diagnosis, but in fact, confirming this would be time consuming and it's not available in times when clinically is needed. Diagnosis. Victims of fire or reported ingestion of cyanide, like those who had some intention or suicidal attempts, those who has exposure at workplace, or those who being treated with sodium nitroprusside in hospitals. I mean, the clinical scenario of the history might tell you or give you some hint about it. So those patients would be considered as potentially cyanide poisoned. Cyanide toxicity should be considered in every smoke exposed patient, especially if they had 2 or more of the following: carbonaceous material in the oropharynx, neurologic dysfunction, metabolic acidosis, or lactic acid, high lactic acid in the blood. Management. Cyanide poisoning is rapidly lethal. It needs an energetic action toward the patient to be treated soon as possible. If clinical history and examination are suggestive of cyanide poisoning, here the priority goes for antidotal therapy, and this should be given immediately. In contrast to carbon monoxide poisoning, as I mentioned in the past, in those patients who were in urge to get high concentration of oxygen, but here the priority goes for the antidotal therapy. Because even if you gave the patient a lot of oxygen with high concentration, this is not going to be used in the tissues because of the cytotoxic or the histotoxic pathology or nature of this kind of cyanide poisoning. Management would include 3 major steps: resuscitation, decontamination, and antidote therapy. Care must be taken in evaluating any patient with smoke inhalation. As I mentioned, carbon monoxide poisoning might be an associated feature here. And not uncommonly, it's seen as a clinical practice going toward diagnosis of carbon monoxide rather than cyanide poisoning, because carbon monoxide diagnosis is more easily done with a level in the blood and this would confirm the diagnosis, but cyanide test in the bedside is not that convenient. And if the patient diagnosed with carbon monoxide poisoning, it needs a bit of enthusiasm to think of an associated cyanide poisoning. So never leave a patient with carbon monoxide poisoning to say that's a single diagnosis, because a patient might have double pathology. I mean, carbon monoxide plus cyanide poisoning. The first step in the management is resuscitation. A patient should be secured with high flow oxygen in spite of the pathology being histotoxic, but high flow oxygen should be given immediately, regardless of what the pulse oximetry tell you, because the pulse oximetry might tell you high levels. Mouth-to-mouth breathing or resuscitation is contraindicated, as cyanide poisoning or cyanide might be passed on to the resuscitator or the provider of the cardiopulmonary resuscitation and might affect him negatively. Any unresponsive patient should have his serum glucose checked, and hypertonic saline or dextrosaline should be administered immediately if the patient had hypoglycemia. Naloxone should be administered to any opioid toxicity if it is suspected as an association with cyanide poisoning, because basically opioid toxicity might be a primary pathology, and the patient might go into certain accident in the house and set fire to himself and present with cyanide poisoning, but still there is another pathology. I mean, don't forget the second pathology that comes with any one of these toxicities, cyanide toxicity or carbon monoxide toxicity. They might have secondary or tertiary pathologies coming and presenting with the patient. Here is the third step, thiamine. Not uncommonly we see cyanide poisoning in patients who were addicted on alcohol and they were intoxicated with alcohol at the same time, and they had an accident with cyanide which came across the pathology. Now, thiamine is a mandatory treatment for any sort of alcohol toxicity through the mechanism of wernic encephalopathy. I believe that you remember that from your lectures of, I don't know, neurology or biochemistry or whatever. Seizures should be corrected and treated with benzodiazepines. The second step is decontamination. Patients should be removed from the source immediately. The clothes should be removed and discarded without being used again, just like in the organophosphate poisoning, if you remember. Thermal exposure, patients should have their wounds and skin being irrigated very well with soap and water. This prevents further absorption, as you know. Cyanide binds poorly to activated charcoal, and gastric lavage is mainly not recommended because, as I mentioned, cyanide is absorbed very quickly, in that the patient presents usually late enough to have gastric lavage is useless. Antidotal therapy. We have three strategies: binding of cyanide, induction of methemoglobin, and the use of sulfur donors. Direct binding, this entails the use of hydroxycobalamin. Here we use a larger dose, like 5 grams of hydroxycobalamin. Now this one forms cyanocobalamin instead of hydroxycobalamin, and as you know, the cyanocobalamin here is stable and water-soluble, readily excreted through the urine. The second modality is induction of methemoglobin. This entails the use of oxidation of ferrous in the hemoglobin to the ferric part. Now the ferric form of iron is very tasty to cyanide. Here cyanides like to bind to ferric instead of ferrous, but this combination turns hemoglobin to methemoglobin. Nevertheless, methemoglobin is more merciful than cyanohemoglobin, I mean cyanide itself. So the formation of methemoglobin, although it's not favored in the blood, here it's excreted more easily than cyanide, but at least it gives an alternative binding site instead of the cytochrome. Here the cyanide is going to combine to hemoglobin instead of cytochrome, but it doesn't combine to hemoglobin straightforward like that. You have to change the iron form of hemoglobin from ferrous to ferric, and this would be achieved through the use of amyl nitrate. Amyl nitrate is available clinically in sort of ampoules. We can break it and let the patient inhale it immediately in front of us. This would give a very good and dramatic improvement. The third modality is sulfur donors. This involves maximizing the ability of sulfur donors for rhodinase. This enzyme, as you mentioned, that it detoxifies cyanide by transforming it to thiocyanate, and thiocyanate is again water-soluble and renally excreted. Sodium thiosulfate is the therapeutic choice here, is a sulfur donor that helps rhodinase enzyme to form thiocyanate. This is the end of this lecture, and hoping the best for the next.